Hello everyone, welcome to the CoROM Podcast. 4 of our faculty members from the college will present 4 podcasts each month. Every Friday, one of us will discuss topics focusing on remote, austere, and resource-limited medicine. I would like to introduce the 4 presenters for this podcast. Dr. Winston de Mello is a retired colonel from the British Army. He ran Battles program, which is where we met about a decade or 2 ago. Dr. Edith Gara is a PhD cardiologist from Budapest who's also worked in prehospital, and I met her whilst working on the Hungarian HEMS program. Tim Cranton is an offshore medic from the UK who taught on the Special Operations Combat Medic program for NATO, which is where we met. My name is Abrigo Kelly. I am a founder of the College of Remote and Offshore Medicine Foundation. I am a critical care paramedic, and I'll be offering monthly podcasts focusing on austere medicine and austere critical care. So Winston, can you tell us about your background and how you got involved with the college?
Yeah, sure. It was a long way around. I spent time in the military from 1976 to 2013. And after obtaining my anesthetic fellowship, I felt that my pre-hospital care wasn't up to scratch. So I decided to sit for the diploma in immediate care at the Royal College of Surgeons of Edinburgh. And I was rather relieved to pass the exam and became an examiner 3 years later. And I've been an examiner for 30 years, just relinquished that this summer. I've always felt that there is a need for pre-hospital care, but I think everyone listening to this podcast, but the educational content tends to vary from place to place, institution to institution. And it was meeting you as an instructor on the Battles course, for which I was in charge of for 7 years, at the height of the Afghanistan conflict, that CoROM was initiated. So I'm one of the founding members of CoROM. And it has been quite a nice side job when I was full-time working, but now that I'm retired, it still keeps my mind active. So that's really the background to my story.
You'll be presenting a podcast on the 4th Friday of each month. What will you be discussing?
Well, it'll be very biased because it'll be my view of life, but I hope to sort of bring in the sort of what's happening around the world. My first podcast is going to be on pulse oximetry and the issues raised during the COVID pandemic. So I think it'll be a nice time to sort of review the uses and abuses of pulse oximetry. And I guess the other topics that will be coming along the way will be similar in flavor. Methoxyfluorine, which is something I grew up with in the 80s, now being reinstated. So really things that I think anyone working in pre-hospital care or low-income countries would benefit from a historical background. If you don't know your history of your subject, you are not a true professional. So I think it is. So my plan is to provide you with the historical background of why we do things in a certain way, and hopefully identify future prospects or future directions at which different clinical scenarios will progress, like, for example, in resuscitation.
Well, Winston, what 2 clinical pearls would you like to share about your medical practice and your experiences?
I think the first one, these are all biased because they've been subjects that I've been involved in. The first clinical pearl is, if you are the first responder for major trauma and you can provide good analgesia within the first hour, you reduce the impact of PTSD by 9-fold. This was published in the New England Journal by Lisa Holgate from San Diego US Naval Academy. And I think that's a paper that really confirmed my belief that the first responder, wherever you are in the world, good analgesia, and it's not just analgesia with opioids, but just a biopsychosocial approach to pain, makes a big difference to outcome. The second is really military, but I think now with the conflicts occurring around the world, it's a paper that I published with the late Chris Davies, Special Forces medic, that if you have a blast injury with a 1 above knee amputation, you have a 25% chance of a pelvic fracture, and it's bilateral, 33%. So essentially the message there is, in blast injury with lower limb amputations, bind the pelvis. And we know when that was introduced as a standard and adopted by the tri-service it saved several lives. So those are my two clinical pearls.
Thank you, Winston, and I look forward to hearing your podcast each month. So, Dr. Gara, can you tell us about your background and how you got involved with the college?
Yes, of course. So my background is in cardiology. I have a broad experience in pre-hospital care and also in cardiac emergency and intensive care. And my special interest lies in heart failure care and also mechanical circulatory support, such as ECMO. My first contact with the head of college was several years ago, and I am a member of the faculty for more than 2 years now and counting. The first contact initiative actually happened through a social media platform, through networking. So this could be a message from me that keep an open eye and an open mouth as well. And by this, you can channel yourself into unique treasures, such as the CoROM initiative. So I'm glad to be here in the CoROM cast.
So, Dr. Gara, you'll be presenting a podcast on the first Friday of each month. What will you be discussing?
Yes, so I will be discussing the most frequent cardiovascular events. So I will talk about chest pain and shortness of breath. I will touch on the acute coronary syndromes, which is, of course, a crucial part in pre-hospital care. I will also discuss physiology background and also pharmacology, without which we can't handle any patient. I will touch on pulmonary embolism and then some symptom-based care like palpitations, collapse, syncope. And I will also touch on the traumatic heart disease, as trauma care and trauma patients also have a huge slice in the pre-hospital pie.
And what two clinical pearls would you like to share about your medical experience?
So 2 clinical pearls I brought. So of course, they are from cardiology or cardiovascular care. The first one is that a myocardial infarct begets a myocardial infarct. So to explain this, I've seen, and it's also in the literature, that one major cardiovascular event triggers the next one sooner than later. In most cases, unfortunately, another cardiovascular event is happening within 10 days. So it could be the case that there's a side branch which is getting occluded, or the patient suffers some thromboembolic complications. It also could be worsening of another stenosis, maybe on the carotid artery. And also within 6 months, the second cardiovascular event comes almost in 100%. So from this, we could take that the secondary prevention and also really close follow-up of these patients are extremely important. The second clinical pearl from my side is that I've experienced and seen that a thromboembolic event is always more serious than the bleeding event. So let me explain this as well. For example, a patient takes aspirin to avoid coronary occlusion, and there is a known side effect of taking aspirin that it causes gastric ulcer, which can bleed. And of course, an infarct is more severe than the gastric bleeding. It's true for the antiplatelet drugs such as aspirin, and it's also more important for the anticoagulants. And it's always easier to handle the bleeding event, and the thromboembolic events are more frequently, they are fatal. You can think about a pulmonary embolism.
That's interesting. I guess that comes into effect for a lot of us old guys who are doing the 75 milligrams daily aspirin.
Yeah, actually, for aspirin, for primary prevention, still today, we don't have any evidence that helps. So in my practice, I don't recommend as a primary prevention the aspirin.
Tim, could you tell us a bit about your background and how you got involved with the college?
Okay, in terms of my background, currently I'm working as a remote healthcare practitioner. I'm now commonly kind of titled HCP. Whenever I answer the phone to our topside doctors, they ask, are you the HCP or a first responder? So we're not really called offshore medics nowadays, we're called HCPs, but that's what I'm doing. Working for United Health, and I'm on one of the last of the Brent platforms. We've probably all heard of Brent Oil. I'm on the Brent Charlie that's currently being decommissioned, and that will be lifted from its topside in the next few months or so, we hope, weather depending. So yeah, currently working in a remote location. I've actually just demobbed over the last week. I am an ex-UK British Army medic and state registered as a paramedic in the UK. But after I did my paramedic training, I decided that I wanted to do something a bit more exciting. So I joined the fire service instead. So I was in the UK fire service for a number of years as well. I left the fire service and came to live in the Czech Republic. I was going to kind of move abroad and was looking for other avenues and getting into teaching, because when I was in the fire service, I actually got into teaching what was then the trauma care courses and introducing defibrillators onto fire engines, etc. And that kind of got me more into teaching. As things have moved on, I was teaching at ISTC, so the International Special Training Centre at Fundorf for NATO. And I got to know about the college whilst I was there. So the college, I think, was doing the trop medical side of the course, the NATO Special Operations Combat Medic course.
That's right.
And I was teaching the tactical combat casualty care and the prolonged field care side of things. And it turns out that everybody kind of knows everybody, and that's how I got to hear of the college. And obviously we stayed in touch from there, and several things came up. To cut a long story short, I was involved in Ukraine after the Maidan in 2014, and soon discovered that there was a significant gap when it came to medical education. And unfortunately, I didn't have the tools to be able to provide it, but I knew who did. So that's obviously when I went back to the college and brought the college together with obviously some of my friends in Ukraine. And really, that's how we kind of got involved with each other. I was invited to come and teach in Malta, I think, on one of the remote EMT courses. And I've been with the college now, I think, for 4 or 5 years now. So I've obviously graduated, as well as teaching on the remote EMT course. I'm now one of the tutors on the year 1 practical side of the BSc training. And very much enjoying my time with the college at the moment.
Yeah, Tim, you were instrumental in getting us into Ternopil State Medical University and running the first paramedic. Well, they have Felters, don't they?
Yeah.
And they wanted a Felter to paramedic transition program in 2019, and you were instrumental in getting us over there for that.
It was a much needed thing, and as I said, I knew I didn't have the materials to be able to do it, but I knew someone that did. So yeah, and it was really good to be able to bring that relationship together.
Yeah, and just in time, isn't it? Hopefully that they're
very
busy
much,
at
very
the
much
moment.
so.
And you spent some time in Ukraine recently.
I mean, I have. I most recently, certainly since obviously the conflict reignited, I think, because it's never really stopped. Yeah, I've been providing or helping to provide humanitarian aid. So bridging a gap essentially between some NGOs in the UK that have been very helpful when it comes to providing medical equipment. A lot of equipment has been destroyed, especially in hospitals and the like. So yeah, I've been quite busy getting humanitarian aid to where it's needed.
So Tim, you'll be presenting a podcast on the third Friday of each month. What will you be discussing?
I am. Yeah, I've got, I think it's 6 topics I've got, and I have made a list. I'm kind of keen for everybody. Don't just believe me. I want to introduce you to kind of other people rather than just myself. So I'm planning to do some interviews. I've spoken to a few people already. So the plan is to interview a critical care transfer paramedic who's a colleague of mine. But he's been very instrumental most recently in repatriating some critical care patients, mostly pediatric critical care patients, from Ukraine actually back into the Czech Republic for treatment and elsewhere in Europe as well. But he not only does that, critical care transfers, he works remotely, so he will do things like providing medical assistance for motor rallies. There's a major one in Greece that runs every year. Most recently, he's been involved in that, as well as providing medical cover on film sets. So I don't know if anybody knows, but in the Czech Republic, in Prague, we've got Barrandov Studios, and they're quite famous for a lot of productions. Most recently, The Grey Man was filmed in Prague. And as a medic, you might be able to work on a film location, and one of those is in Prague. So I'm hoping he's going to talk to me about those things. As I mentioned already, I'm working offshore, and I've actually spoken with my offshore installation manager, and I've asked if he would be interested in doing a podcast to tell us actually what life is like offshore and how he interacts with the offshore medic, and the role that the offshore medic plays in the offshore oil and gas industry, particularly on a rig or a floating production facility. Also about setting ourselves up for success. There's some do's and don'ts that that I kind of want to discuss when it comes to being a medic in a remote location. And I've kind of found over the years that some guys will turn up and they're actually very poorly prepared, not necessarily because of their own ignorance, they just really, kind of don't know. So I kind of want to help people, and I've got somebody lined up. I don't want to name names just yet, but I'm hoping they're going to help me out, who's going to help us when it comes to being prepared. I'm also looking to interview with a paramedic and safety inspector from the Organization for the Prohibition of Chemical Weapons. Essentially, these are podcasts around the type of job that you could end up doing in a remote location. So from film studios, oil rigs in places like Yemen, Syria, working for the OPCW. And then I've got another one lined up. I'm hoping that I'm going to be speaking to one of the offshore medic training providers and the things that they're looking for when it comes to people looking to train as offshore medics or looking to go into the oil and gas industry. There are prerequisites, especially when it comes to, pre-qualifications, things like ex-army, ex-military, a nurse, and also a BSc student from the college as well. So the kind of thing that somebody, an ex-BSc student could do, go on to an offshore medics course. And really, I wanted to talk to everybody about how you go about getting a job. It's one of the things I think I get asked the most as a medic. How do I get a job as a medic? How do I get a job as a medic? So I'm going to try and give my own kind of version of what I think you can best do to get yourself employed. Certainly one of the things I will say is those jobs don't come looking for you. You need to go looking for those jobs. There's a few of us out there, and there's a lot of very good guys out there as well. So you're in competition with them. So essentially, you need to know what to expect, what to look for, and how best to prepare yourself when it comes to getting a job in a remote location.
That's going to be pretty interesting. So many people have a concept of what precisely we are doing in remote and austere, and there's probably some niches out there that a lot of people know about.
I mean, right now I'm talking to guys that are in Mali, working for the UN, working as medics, as first responders. Those guys tend to come from a very military background, kind of a combat medic background, so they're not doing too much clinical general practice type work. They're mainly concentrating on kind of pre-hospital care. But that's there. If you go somewhere like on a film set in Prague, you're looking after actors who can be quite needy, and it tends to be the little niggles, the aches and pains, more kind of general medicine. It's the same, being offshore. We don't see an awful lot of trauma. What we need to be concentrating on, I think, certainly is having a good knowledge of general medicine.
That's pretty interesting. Yeah, primary care is very much what we're seeing in remote settings. All the cool guy stuff is not as common. But so, Tim, what are two clinical pearls you'd like to share about your medical experience?
I'm going to sum it up, I think, quite simply. Don't panic. Fly the patient. It draws me back to when I was doing my paramedic training. I was in A&E at Peterborough. We had a patient, polytrauma. He had gross facial injuries, bleeding into his airway. I was a brand spanking new paramedic. I had an anaesthetist who was my mentor with me. I was frantically suctioning out this patient's airway. And the whole situation, I think, was it was quite overwhelming for a new paramedic. And the anaesthetist was stood right next to me, cool as a cucumber. And he said, breathe, don't panic, fly the patient. And I was kind of I don't really understand what he meant. He went, you've got your checklist, haven't you? I went, checklist? Yes, I've got my airway ladder. Okay. So he says, right, let's go back to the basics. What do we need to do? Work your way through your checklist. And I think that kind of sums it up for me. And what does a pilot do if number one engine goes out? He reaches down, he picks up his checklist, and he goes through the checklist, a stepwise approach to patient management or critical management. And that kind of fixed it for me. So we've got our algorithms for advanced life support. We've got our algorithms for various things. It kind of brings me to the CoROM field guide, which is extremely helpful when you've got an awful lot of things to think about in a situation where you're trying to make decisions on what to do with your patient. So like I said, don't panic, fly the patient, take your emergency checklist, work your way through the checklist. And then if you need to, you can jump off and you can come back in, but you've always got a place to come back to be able to manage the patient. And it's worked for me ever since. It's kept me calm. It's always given me a place where I know I can go back to. And it helps to stop me making any mistakes, so I can provide my patient with the best level of care. And the next thing is stay current and continue to learn. I think the biggest thing I've learned since I've been with the college is the need, most certainly as a tutor, as an instructor, as an educator, is the need to stay current with research, with medicine. I mentioned general medicine already. There's an awful lot out there. I'm not a doctor, but there's an expectation on me, to provide general medicine and general practice. So I need to stay up to date. So stay current, stay up to date with all of the medical papers, do your research, go down the rabbit hole. It can reveal some interesting things sometimes, and certainly things that you didn't know and you learn. And continue to learn. Never stop learning. I learn something new every day.
That's very valuable. The whole checklist manifesto has transformed medicine, hasn't it? And that wasn't that British? Wasn't that the UK that came up with that, Winston?
The WHO checklist has transformed medical practice. The reason why I feel very proud of it was because a very small hospital in Tanzania, St. Joseph's, I believe, in Tanzania, that's one of the pilot studies. So I would have thought that WHO checklist before surgery, which I guess has probably been one of the biggest impacts on survival in following surgery in certainly in low-income countries where there wasn't a system. So as Tim has mentioned, if you've got a system and you know it well, you can operate when times are difficult. You can deviate from that system as you get more experience. Like Edith, I would expect to be more au fait with the cardiological emergencies. But as a general practitioner, I wouldn't even pretend to be anywhere that level, but I would like to think I would provide the basics. So I think these podcasts would work two ways. I would learn from Edith in terms of cardiology, so it's just nice, as Tim says, to keep fresh as to what's going on. It's often better learning from somebody who's doing it. I've never liked people who lecture but don't have the gravitas of actually doing the job. For me, it's William Osler, who said doing medicine is like going to sea. You can either stay at home with all the maps of the seas, or you can go to sea without a map. And basically, it's theoretical knowledge and practical application. And the best combination is both. So I'm excited because I'm looking forward to hearing other perspectives from Edith, yourself, and Tim. And also, I think, trying to sort of work out what can be translated from hospital practice to pre-hospital care. That translational medicine is very difficult. We can't make any advances in pre-hospital care until somebody picks up the challenge. So the best we can do at the moment is actually transferring hospital service, general practice service into pre-hospital care as an adaptation. But my hope is that the students doing the BSc and the MSc within CoROM have the opportunity to pick up and record data and work out what's good for the environment that they're working in.
That is a challenge for our students. You're right. And hopefully some of the doctoral dissertations, some of the master's theses could translate evidence-based best case medicine into practice in Tanzania or practice in austere environments. And that's kind of what the college is about, is trying to bring evidence-based medicine into difficult locations. It doesn't matter if you're in the middle of an oil rig in the sea, or if you're on a cruise line, or if you're in the middle of Mali. Medicine is medicine. And yeah, we should bring the best of medicine into that environment and not lower our standards.
I think a good example of that is the case of the need for appendectomy. It has been shown that if you treat patients with antibiotics versus surgery, the outcome is the same. And I think until you do the research, I mean, the Royal Navy have been doing that for years, mainly in submarines where they're out of touch with surgical care. And I think working in the military has got some lessons for civilian care and vice versa. I think when the military is busy, it overtakes and becomes very pragmatic approach to whatever that problem is. As Tim hinted, CBRN, trauma is not a problem, but CBRN, viral pandemics are going to be problems for us for the future. So we have to learn from those lessons, and it's in peacetime that the civilians actually catch up. So there is a changing of the guard. I think in military, when the military threat is at a high level, medical care tends to improve, mainly because of pragmatic reasons. I've been involved in high tempo trauma in Iraq and Afghanistan, and now civilian trauma hospitals are using it all over the world. And when you consider Camp Bastion was regarded as the #1 trauma center in the world, without doubt, and to have worked in that environment, you then begin to realize doing the basics well is the message. You don't need fancy stuff. You just need, and especially when you're in a low-income country, then you're limited by finances and resources and expertise. And I think that separates the men from the boys.
I like to push that concept, Winston, of knowing the basics well. People ask me what makes special forces special, and my answer to that is always we're special because we know the basics very well, extremely well, and that's going to be good for our casualty. It's going to be good for austere medicine. That's the #1 thing, isn't it? We got to be really good at the basics, and then we can build from there.
There's an expression that I like to use. We do not train until we get it right. We train until we cannot get it wrong.
Yeah, that's really true.
I remember being a cop in the 80s, and that we were taught you shoot or you train until you get it right, and then you stop. And we didn't. We got it right once, and then that was fine. And that's absolutely not the way to do it. Yeah, you got to keep going until it's
that analogy. Practice makes perfect. No, it doesn't. Practice just makes you good at what you're doing wrong. You need to get it right first, and then keep doing it, and don't stop.
Any other comments, guys? This is some good back and forth here.
Let me just reflect on the checklists.
Sure.
So yeah, I love them actually. I'm really fond of them. And when I used to work in the UK, I was surprised at how many checklists actually you guys use there, which is really cool and gives high quality patient care and patient safety. And when I'm comparing the use of checklists in Hungary, so actually in pre-hospital care, it's pretty common. But unfortunately, in the emergency units at the hospital and also in the ICUs, still not that common to use the checklists. And it's funny that a patient would even ask you, if conscious, that, hey, doctor, you have to read that. It's not in your mind. So what's going on? So it's still not really common to use them. And
that's interesting.
Yeah, the old-fashioned doctors, they feel that they can do or they know everything by heart, and they can always improvise on the bedside, and they simply don't need the checklists, and they don't understand the fact behind the checklists and why are they used to. So in my experience, in my practice, I can't remember any patient or any case when actually the checklist failed me or failed the patient care. Maybe Tim, do you remember any time when a checklist was not helpful for you?
Yes, when I couldn't find it. and I mean that sincerely. So I've always made a point of having a checklist, whether that be a copy of my CoROM field guide or a laminated copy. If I go to a certain site, I will put it inside the med bag. So we'll have a big crash bag, a med bag. So I know I can go there for my ALS guidelines or whatever, or my trauma guidelines, my primary assessment guidelines. And I remember attending a patient and thinking, right, in my head, I'm going to open my bag. I'm going to take out my checklist. I'm going to hand it to my kind of lead first responder, and he's going to talk us through as a team this scenario, making sure that we get everything right, whilst I do the procedures that require skill, etc., etc. And it wasn't there. And what happened is one of the other medics, you kind of said it already, Edith, felt that he didn't need it, so he threw it away.
Mm.
And essentially the team dynamic was lost because the other members of the team who don't necessarily have as much experience as us as the primary practitioners, they're looking for that level of support. And when they don't have it, they're losing a level of guidance. And then so it increases the thought processes that you as the lead medic have to make. So it puts even more stress on you, which I think means potentially you can forget more, or you will omit something that is vitally important. It's like your 4 H's or 5 H's and 5 T's.
Sure. Yeah.
Absolutely.
You know, having that written down makes a big difference when it comes to memory recall and when you're working through it. And when somebody stood there saying, right, 4 H's, 4 T's, have you done this? Have we done that? It makes a huge difference. Fly the patient.
I think the thing about checklists is that they're very useful, but you've also got to make sure that the people using the checklist follow it. Let me illustrate. Kosovo during 9/11, I was serving with the US Army, and we had 5 major trauma bays. And unfortunately, we had 6 casualties come in. And there was a makeshift 6th bed run by senior NCOs who were all battles trained. At the end of that mass casualty situation, it transpired that the best care was given by the senior NCOs who followed the checklist of battles. The trouble with the other 5 bays, where the consultants were involved, each person felt that they wanted to have a debate as to whether we should use normal saline or Hartmann's, or should we give analgesia or not give analgesia, should we protect the spine or not the spine. So I think in fairness, checklists are great if everybody in the team follows it and it is not for debate. The debate comes in peacetime, and you bring in the evidence and you make sure that the lessons you learn. This is why I find it very frustrating dealing with paramedics who work on their own. And they say, I want a job. And I say, how good are you? And they cannot provide me with the evidence of outcomes. And I've always said to all my students, if you're dealing with patients, before you go to bed, write down what you did today, reflect on it, do a Gibbs reflection, it doesn't take long, and then learn. And I'm afraid until paramedics try and look at short and long-term outcomes of their patients under their care, the specialty will not improve. And so we've got a long way to go. And the only way you're going to do it is by collecting data. And this was started by General Tim Hodgetts many years ago. Collected data. Paramedical sciences is a black hole of data. So until somebody comes up with data, nobody's going to pay any attention. I think that's the challenge. And I think my sincere hope, CoROM provides the basis for challenging, renewing, adapting, pragmatic changes in clinical care.
That is a valid point, Winston, and I think that's the only way forward. And there's more and more PhD level paramedics. There's tons and tons of master's level paramedics. I hope here at the college that all 3 of you guys, as you're mentoring our students, that we're forcing them to be reflective, forcing them to learn from their mistakes, forcing them to grab that data and do something with it to push medicine forward. I completely agree with you, and it shouldn't be a black hole. It should be a give and take. So we shouldn't just be using lessons learned in ICU and bringing it into austere environments. We should be able to have lessons learned in austere environments and push evidence-based medicine worldwide.
One of the things that we're seeing more and more of, certainly over the last few years now, and this is a good thing, and it's certainly something that I believe in, is CPD. So continued professional development. It's now not a nice to, it's a you will. So the HCPC, if you're state registered as a paramedic with the HCPC, you must, in order to maintain your professional registration, demonstrate that you are doing CPD, that you are doing reflective practice. One of the things that I do for every patient is I always take a few notes on the patient. so that when I'm writing my CPD for the year, which I now have to submit not just to the HCPC if they ask for it, so it has to be there, but also to United Health. So my employer demands it as well. They also watch what we do in terms of all of the clinical interactions that we have with patients must go into a system called Medbase. So it's recorded. So every offshore medic that works with United Health and Shell, we use Medbase. And now we have a clinical lead who's obviously shoreside, and they go through all of our patients, and they will see what we've been doing. They'll see how we've been doing it. And then they'll come back to us, and they will have conversations with, why did you write this? Why did you make this entry? Why did you not contact topside? Do you not think you should have contacted topside? I see you did contact topside. What was the discussion you had? And that's all recorded. Obviously, it's patient in confidence, but that data is there in order for us, I think, as a clinical team. And when I say clinical team, I mean the group of Shell medics, and that's shared within the group. And we now have meetings, usually on a fortnightly or monthly basis. All of the medics on the installations attend. You can attend also if you're on your leave time as well. And we'll go over things like certain patients. What did we learn from this? How can we improve as a group if any of us get this patient at any time? One of the biggest challenges we've had at the moment is COVID, and how we manage COVID patients in a remote location where we can't just send them home or whatever. And I think that's been a huge learning curve for us, certainly over the last year or 2 years. So it's something that's maybe not as good as it could be, but it's getting there. But it's taking, some companies, thankfully, my employer, United Health, are taking the lead. It's a work in progress, I think, Winston, but there's a lot of work to go yet.
I think as paramedics, we need to utilize that physician top cover and have a good conversation. And even as physicians, if I'm wrong, correct me, but as physicians, you do grand rounds once a week, don't you? You have cases that are interesting that you bring to the table with a whole bunch of other specialties, other physicians, and you go through these cases and see if there's any changes or mistakes or improve, or what can be done differently. Are you seeing that from in
I think the interesting thing about complex cases or lessons learned, I think the quickest lessons were in Camp Bastion. If there was a death in the hospital, within 24 hours, a senior non-involved clinician would go through the patient's journey and present the data within 24 hours of the death of the soldier, so that lessons could be learned and the speed at which changes could be made. I mentioned the pelvic binding following above knee amputation. This is not. This was done by a special forces medic, the late Chris Davies, who wasn't doing a PhD. He wasn't doing a master's. He wasn't doing a BSc. He was just following instruction from me about this problem, and he spent hours and published the data, and it is now one of the most quoted papers on pelvic injuries. So I think pre-hospital responders have a gold mine of information. The trouble is they need to be guided, and that's where I see CoROM playing a role into what is possible, like our student in KCMC doing burns, for example.
Dr. Gara, I wanted to ask you if you, as far as grand rounds or physician review, what do you do in Budapest with reviewing patients?
Yeah. So and every Friday 1 p.m. so at 13 o'clock, which Friday 13, it's kind of bad luck. So at that time we have this weekly case discussions, and as some resonates with some bad luck, unfortunately, some mistakes, failures are always included, and it's really heavily debated discussions are presented at this times. And I would say that this is the part where art lies in medicine. So this is the part which is not written actually in the checklists. And like from the highest professor to the medical student, everyone learns many important new information from these talks. So I absolutely agree with you guys that the continuous development and continuous training is the key for our practice.
Our hour's about up. Do you guys have anyone have any comments that you want to put out before we end this first podcast?
I don't think so. I think if you're interested in education, as we are, get in touch with the college.
That is it for our introductory podcast from the college. I would like to thank Dr. Winston de Mello, Dr. Edith Gara, and Tim Cranton for joining me on this venture. This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn free CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is CoROM, CoROM, corom.org.